Okay, you ready? Okay, my name's David Gillis. I'm a clinical allergist. I also work in the lab in Australia. This talk is really going to be my personal view as to how the newer technologies in allergy fit into the clinical. It'll be a bit of a historical throughput in terms of where we're up to, and then how the component resolved diagnostics builds upon these historical improvements. It's also going to sort of emphasise both the promise and also limitations of this technology, particularly in terms of clinical diagnosis. It's called the Allergy Old and New, and I'm sorry for some of you who already know this very well, but I think I have to get some background and some sort of clinical background first, and then build upon this sort of clinical background to see where these techniques fit in. Yeah, now there's no webcam because unfortunately the internet connections were such that I jerked all over the place, and I'm a bit of a jerky person anyway, and this was beyond a joke when there was jerkiness on jerkiness. So we all know the mechanisms of allergy. We know that what we're talking about in terms of allergy is IgE-mediated disease, and we all know that IgE to allergen cross-links receptors on mast cells that leads to the allergic response. At least in Australia, the diseases we're looking at are two principal diseases. One is, in fact, atopic-related disease, but the next big area that we look at in Australia is anaphylaxis, and also we have this sort of pseudo-allergy, which is a sort of non-IgE-mediated allergy involving mast cells, but the mechanisms of which are slightly unclear. Now, the big area, two areas I deal with in clinical practice in allergy is firstly clinically IgE-mediated disease, rhinitis, asthma and eczema, and there is plenty of evidence that there is sensitization here with specific IgE positive in these diseases, and testing and specific IgE in serum, and essentially as well as the sort of clinical aspects of this, there is also the family history aspect of atopy. So that's one big group that I deal with, and we all know that atopic disease is increasing, and all of it is increasing, and it's increasing in a sort of sequential fashion. There was an increase of asthma and asthma death to start off with. There's now an increase of rhinitis and eczema, and also an increase in particular of food allergy. The other big area I deal with clinically is the severe life-threatening reaction of anaphylaxis. This is separate because it can occur in non-atopic individuals, and essentially, except for food anaphylaxis, frequently it occurs in non-atopic individuals, and essentially the clinical aspects of this is food, medication, and insect venoms. And we have a fair bit of insect venom anaphylaxis here, and I understand in the United States it's very similar in terms of wasp and bee. Medication is important because this tends to occur in an older group, and there's a bigger death rate of this, and also there's food anaphylaxis. Now, one of the things I need to emphasise in this business of allergy is that it's a moving feast. Essentially, we have, and what we can say is in terms of anaphylaxis, this is quite common in terms of the fact that we used to have peanut anaphylaxis, and this has vastly increased in the last 20 years. In our Australian cohorts, it's double what it was 15, 20 years ago. But also we get newer aspects of different allergens coming on board, and this is dependent upon the increase of consumption. So essentially we had peanut increasing, more recently we've had cashew nut, and now we've had Brazil nut. And this is really related to overall world consumption and also the price of these nuts in terms of them being used widespreadly in foods. Likewise, we used to see a lot of penicillin anaphylaxis, but now all the studies across the world would say that cephalosporins have superseded penicillins as a cause of anaphylaxis. And then, of course, because we all eat prawns rather than fish now, prawn anaphylaxis is increasing. And once again, although latex anaphylaxis was an important cause a couple of years ago, now chlorhexidine is more common. So essentially, the first thing I want to say is that the allergens of today are going to be different from the allergens of 20 years ago and perhaps the allergens in the future, and this has to be borne in mind. Now, why do we do allergy testing? Well, there's two reasons. Firstly, we have to say, is allergy causing the clinical problem? And what allergen is causing the clinical problem? And the second question is the most common question which gets asked. And essentially, there's a lot of different ways in which we can prove or disprove that allergy is causing the problem, and the historical history is the key in terms of the association of that allergen with the clinical symptoms. And that's really important to emphasise, that we aren't doing testing in a vacuum. We're doing testing in the context of clinical history. And then I don't have to tell an audience like this that skin testing has been around for a long time. Then there's specific IgE to allergen. And then there's challenge with allergen with a which is a gold standard for foods, and also response to immunotherapy. So there's a large range of things causing the problem. Now, traditionally, skin testing has been what we've used for allergy testing, and this has been associated with history, positive skin tests, and preceded by specific IgE to allergens. And the common allergens we have in Australia are couch and house dust mite and bee and ryegrass. Now, originally what happened is that specific IgE to allergen was a secondary test to skin testing when skin testing was unavailable, when there was interfering medications or eczema, and also with young children and dermatographism and anaphylaxis. So originally, skin testing was the gold standard, and specific IgE to allergen was a secondary test. And I have to emphasise this because this explains the history of the improvements in specific IgE to allergen, which were sort of done in this clinical context where people did a history, they did skin testing, and then it was felt that in fact with these indications there should be tested specific IgE to allergen. Once again, the serum testing originally was this sort of proprietary named RAST testing, and then more recently, the Bardia, Siemens, a whole range of other manufacturers have produced improvements on this testing. The actual sort of principles of this testing haven't really changed that much, as the audience knows, that you've got a solid phase allergen, you add the serum, which contains the specific antibodies, you separate out the bound from the free, and you add a labelled anti-IgE. And this is sort of my very, very crude interpretation. You get the allergen in the solid phase, you add the serum, and you add the anti-IgE. Now, this is what I want. This is my main message, that a lot of the improvements to start off with in the last, say, 10 or 15 years have been due to improve the sensitivity of this assay, to pick up stuff that skin testing picks up, but the in vitro assay doesn't pick up, and that's been for over a long period of time. The most recent improvements have been in trying to improve lack of specificity, and this is the bugbear of clinical allergy. You have a lot of people with positive tests but do not actually have the allergy when in contact with the allergen, and this is the second phase which we've been trying to encounter improve, and this has been the lack of specificity. And so I want to sort of go through lack of sensitivity because, and how this has been sort of addressed, because this sort of ties in with the second phase of improvements of lack of specificity. And essentially, the requirements for good clinical practice, in my own mind, are firstly, the test has to be as good as skin testing. But secondly, it has to have high specificity, because what you need to do is you need to test, and you need to say, look, that if that test is positive, then if I challenge that person with the allergen, then the person will react. So high specificity is important for foods, because you really want to sort of say, test it, say, well, if you're negative for that test, you won't react to that food allergen. If you're positive to the test, you will react to the food allergen. And there's quite a high bar in terms of clinical testing, because you really want to make sure, because you can't go around sort of giving foods to these people and then reacting, or in fact making sure, restricting their diets for no reason. So you need a very good test. So specificity is very important, and also high specificity is very important in terms of aeroallergen immunotherapy, because you're going to subject them to sort of 4 to 5 years of perhaps injections or sublingual drops on the basis of your testing. So high sensitivity is important in terms of the fact that tests have to be as good as skin testing, but high specificity is very important in terms you're dealing with sort of reactions to foods. You might have to make sure that the test completely rules out and completely rules in, if possible, reactions, and also with the immunotherapy as well. So I just wanted to sort of put that down as a sort of clinical sort of feeling. So the aim one, and I'll just whiz through this, was firstly to make the RAST as sensitive as skin testing, and this was done by a range of manufacturers. I'm sorry I've used the proprietary RAST phrase again. And the first thing was to increase the sensitivity by increasing the allergen bound in the solid phase. And this was based on the fact that if you put enough allergen on the solid phase, then you would suck up, like the sticky bun does with the sugar and everything else, you would suck up all the antibodies in the serum, and therefore the binding would not be affinity independent, and therefore you'd have all the specific IgE sucked up onto the disc, and therefore you'd be able to measure all the IgE to that particular allergen, and so it was as good as skin testing in terms of sensitivity. So that was the first thing, and this was done by a large range of different systems, and I'm sorry, and Fadia's allowed me to use this slide, but there were other systems, and I just happened to have these around. So essentially, a number of systems were made, and one of them was the ImnoCap, which had a lot more sort of area bound for the allergen to bind, and therefore that was able to suck up a lot more IgE, and therefore it was able to increase the sensitivity of the assay. And it was claimed, and I think there was some evidence, that there was enough IgE sucked up, and in comparison with the total IgE, you could do parallel curves. And this led to the importance thing. And a number of the manufacturers have done the same thing in terms of you could convert a qualitative test to a quantitative test. So this firstly there was increased sensitivity, but secondly you could increase it to an extent that you could now in fact do parallel curves with total IgE and lead to a quantitative test. And this has in fact improved things. And essentially also you could do quality control testing, and you could get reproducibility between labs, and we have locally we have our RCPA, external quality control, and stuff like that. Now, having said that, the second phase has been to improve the specificity of allergy testing, and I want to sort of spend the rest of the talk about this. And this has been a real bugbear, and this is a work in progress, and I think it'll be a work in progress for a long time. And none of the improvements, I'll just underline this, none of the improvements recently have improved specificity of allergy testing sufficiently for us to be comfortable in a clinical sense. They have improved it somewhat, But it's not like the improvements of sensitivity, which have been remarkable and very good, but the improvements in specificity have just not quite got there, and I'll take you through this for the rest of the talk. Essentially, the causes for low specificity are numerous, but essentially what's happened is you can be sensitized to a particular allergen, but once that doesn't really mean when you're in contact with that allergen you're actually going to react, or you have clinical allergy. You may have sensitivity, specific IgE to allergen, but essentially a lot of people have specific IgE to foods, and yet when they take that particular food they're fine. And this is related to the type of antibody, the affinity or fine specificity or specific activity of the antibody itself, so that the antibody itself doesn't lead to the reaction. But also, I have to emphasize, there's a lot of non-IgE mediated factors that interfere. There's interfering IgG, there's problems with the sort of mast cell and how it reacts to the specific IgE, and also there's how the histamine impacts on the vessels and the immune mediators, etc., like that. So the association between sensitization and clinical allergy is very complex, and therefore just altering a test to make it better doesn't necessarily improve specificity, and I think we have to emphasize that. I will concentrate on food allergy because this is where a lot of the attempts of improving specificity have gone into, and where it's quite remarkable what people have done, but once again it hasn't led to the be-all and end-all of solving all these problems. So in terms of measuring specificity for food allergen, what has been done on repeated occasions is you measure a level of specific IgE to food. So now you've got a quantitative test for IgE, you can actually have a level, and then you challenge with the food under controlled conditions, and then you record whether or not the food people react in a standardized way, and you compare the level of specific IgE to the probability of reaction to food. And this has been made possible because of both improvements in the clinical area and the lab area. And I wish to emphasize that there's been vast improvement of food challenge protocols and reproducible food challenge protocols, which without that we wouldn't be able to look at the in vitro testing in comparison. There's been improvements of reproducible assessment of reactions to foods in terms of the clinical arena, but also there has been the ability to quantitate specific IgE measurements. So all these three improvements in clinical and lab practice has led to our ability to look at specificity in a lot more scientific fashion. And this was sort of arose from sort of Sampson's work in the early 90s, last century. So I'm a little bit behind still. And essentially what they did is they measured RAST in kilunits of antibody per litre, and then they looked at the IgE antibody concentrations for egg, peanut, milk and fish, and as has been done on numerous occasions, they looked at the levels above which there was a 95% specificity for clinical allergy. In other words, there's a specificity of 95% above which you get clinical allergy. That doesn't mean that 95% of people react, because that's obviously the positive predictive value, but at least there's a specificity of 95% above which above which there is a specificity. And clinical allergy is defined as positive challenges to food. So this is the sort of graphs we have on numerous occasions. We have a probability and a capped RAST. We have a certain level above which there's a 95% probability of reacting. Remember, in clinical allergy, obviously it depends upon how good we are in terms of diagnosing people. So if we would take a whole population and screen them, we still would have a poor positive predictive value for 95% specificity, as you know. So this only works if we get people with good clinical histories, and then we take 95% specificity. So this is great. So you have a cutoff, above which there's 95% specificity for reacting to that food and actually having clinical allergy. The trouble is if you look at the people who have below these cutoffs, you still have a large number of people who will still react to the food. In other words, you know, it's fine if you're above this cutoff, but if you're below this cutoff, you may still react to that food. And in fact, 50% of patients in the peanut literature with positive challenges who are below the cutoff are below the cutoff and have positive challenge. And so what happens is if you're 95% and you're above the cutoff, above that 95% cutoff, you're fine, but if you're below the cutoff, then you still have to challenge, and that may be up to 50% of patients. And the other problem with this is, you know, you really want to know who's going to get anaphylaxis if challenged, and the strength of the reactivity with IgE does not predict this, and this is another problem. And the next problem is, as I alluded to before, if you take a sort of low prevalence population, if you screen, then you're less likely to have a clinical allergy, even if you're above the cutoff. So it wipes everything if you don't have the right population. Allergens, I'm not going to go into, but with this cutoff principle, yes, it sort of works. Specific IgE levels correlate with inhalation challenge to cat allergy. Specific IgE does correlate with the concentration. However, it's not perfect. And also, we're bugged by the lack of well-documented and easy-to-do clinical measurements of reactions to cat or house dust mite. Okay, so let's get to the topic in line, and I wanted to give that very long introduction because, you know, I think it's impossible to sort of understand this area without actually having this introduction. So what next in specificity? Component resolved diagnosis. And I unashamedly am going to do a whole lot of Fardia's slides to point the rosy picture, and then I'm going to sort of go back and say, well, it isn't really that much rosy. And Fardia once again has allowed me to, or their local abacus has allowed me to use these slides. And it's some slides I just got out because I thought, well, let's point the rosy picture and then sort of slightly demolish it. So essentially, you know, as you know, allergen contains thousands of molecules, and this won't take long, of which only a few are allergenic. And so, you know, you can actually extract, obviously, specific allergen components from the allergen itself, and you can distinguish between specific allergen components to a whole lot of components which are cross-reactive, and the assumption is the important IgE is the IgE to the specific component. So essentially, if you have an IgE to a cross-reactive component where it occurs in other foods and stuff like that, it's less important, and I'll discuss that later. And also, if the IgE is to a stable allergen, then that's important and more critical. And essentially, obviously, if the IgE is to a component which is quite plentiful in the food, then it's more important. So you sort of build up a sort of priority list of IgEs, where IgEs to specific is the most important, that causes reactions. To cross-reactive is less likely, and to more labile products is less likely. So IgE to specific is genuine sensitization. So they take ARA-H2 and GAL-D1 as an example. Cross-reactive, not so important because obviously it's reacting to cross-reactive food, so presumably less important. If it's labile, it's less important, but if it's an IgE to stable, it's important. And, you know, they build up a list of proteins. So profilin, obviously, is a protein which is a bit more labile, so it breaks down in the stomach, and therefore it's less likely to be important. And whereas lipids transfer proteins and storage proteins are much more stable proteins, so IgE against these sets of proteins is much more important. And so increased risk of reaction. And this is very much likely. These are labels. Protein is less likely to get to the stomach and cause systemic reaction, where the stable protein is much more likely to get to the stomach and cause a systemic reaction. And this is exemplified in their little in their thing, which is quite good in terms of sort of message, but has had problems, I think, in terms of being a little bit too optimistic. ARA-H2 and 1 and 3 are storage proteins, so they're stable, they're in high amounts, they are more specific, slightly more specific, and so these are likely to be the problems in peanut. Profilin is in low amounts, it's unstable, and therefore it's less likely to be a problem in peanut. ARA-H2 is in low amounts, and therefore it's less likely to be important. And once again, ARA-H9 is in low amounts, so less likely to be important. And so what you see is by testing against individual components of allergens, you can assess clinical risk, you can explain symptoms due to cross-reactivity, and you can identify the specific immunotherapy. And so this is the sort of thing. You have Emma, who has a local reaction to peanut, both have local reactions to peanuts. Emma has antibodies against ARA-H2 and 3, and therefore you're really worried about her, whereas Carolyn, who's also of the same age, local reaction to peanuts, has antibodies against ARA-H8, and therefore this is a cross-reactive antigen, and therefore you don't have to worry. So the theory goes. Okay, now I'd like to say that yes, there is some evidence that component-resolved diagnostics like this works, as in these slides, but in some ways what's happened is this technique has come on board. It's brilliant technology in that we can sort of do recombinant antigens and stuff like that, but it's more of a technique that's been looking for a use. And it has a use in terms of what they say, but it's a little bit more complex. And translating into a clinical scenario and clinical use is a little bit more difficult. Now I'll just go back to the sorts of what we want to do. We want a more specific antibody, IgE antibody, and we want it more specific than the specific IgE to whole antigen. So we've got skin testing, we've got specific IgE to whole antigen now. If we want to improve on it, we really need to improve it in terms of specificity. And what we mean by this is that the IgE has to have a better correlation with positive challenge in terms of food allergy. And what this means, harking back to what we've done before, is we all know that if we can get a cutoff with 95%, above which there's 95% specificity, and that's fine, and we can do that for both the newer technology or the older technology. However, the problem with the older technology is we've still got this large proportion of people who still react below the cutoff. So, as I mentioned, in peanut allergy, 50% of people react who react to peanut are below this cutoff. And so the whole point of having these newer technologies should be to actually reduce these number of patients who actually are reacting and who are below the cutoff. And if possible, a better technique would be those that better correlate the severity of reaction. We're not going to get over this problem if we have if people start screening whole populations with these antibodies. No test is going to help because essentially the prevalence of the condition is too low. So all these testing are sort of dependent upon the fact that people have to have test in an appropriate population. So this is the sorts of bottom line, and what I'm saying is, and I just want to, if you could hold on there, and I see some of the attendees have left already, but I just want to sort of, if you're going to just sort of hang on for another 5 minutes, because this is the bottom line. this is the example of Ig to ARA-H2, which is a component-derived molecule from peanut. And what it's shown in this study, in this Dutch study, is that if you actually try to get this 91 or 95% cutoff and use ARA-H2, then what's happening is that the ARA-H2, yes, you can get 95% specificity, and it improves the sensitivity below the cutoff. In other words, the ability to pick up people who react below the cutoff goes sort of up from, say, above this cutoff. 70% of people who have above this cutoff will react, and only 30% of reactors will be below the cutoff. So the bottom line is this component-derived testing, what it does is it reduces the number of people who will react below the cutoff, but it doesn't reduce it completely. So in normal using specific IgE to whole allergen for 95% cutoff specificity, you'll get about 50%. You'll pick up 50% of reactors. What the component-derived testing will do is, for the 95% cutoff, it will reduce this figure to about 30%. So you'll still have people who react below the cutoff, but it'll be lesser. The trouble is what you need clinically is down to 10 or 5%. You really need to reduce that figure who will react below that cutoff for it to be useful. So it sort of helps, but it doesn't completely eliminate those people who will react and are going to be below the cutoff. If I'm with you, and you can ask questions if you don't understand it. And essentially, all these sort of next couple of slides say exactly the same thing. So if we're going to sort of take the 95% cutoff, 95% specificity, so this is a ROC curve, and we're taking the 95% specificity, and we say, well, if it's 95% specificity, how much of the reactors are we going to sort of pick up in this 95% above 95% specificity? And it's about 75%. In other words, we still have 25% below that cutoff who are still going to react. And this is the Australian study, which was done a couple of years ago. And once again, very similar things. If we take the 95% specificity, which is here, we will still, for the ARA-H2, still have about 20 or 30% below this cutoff, which will still react. However, we'll pick up 80%. This is a lot better than most other modalities. It's sort of marginally better than skin testing, but it's a lot better than the specific IgE to whole peanut. But it still has this problem in that even if we take, even if we have a cutoff above which there's 95% chance of reacting, then we still have this group, this irritating group of patients, they're not irritating, but this problematic group of patients who are below the cutoff, who still react. So it doesn't prevent us, we still have to challenge patients whether or not they're above, if they're below the cutoff, because we don't know whether they're not in this residual group. Same thing with egg and milk, in that if we look at the 95% specificity, we still have this 70 or 80% sensitivity with BOS D8, who will react will be picked up in 95%, but still we have this 20% who will still react and are below this cutoff. And once again, with Goldie 1 for egg, once again, it is if we take 95% specificity, then we still have 20% of reactors who will be below this cutoff. So essentially, it's improved matters, but it hasn't improved matters sufficiently for us to be used as a standalone test, and it definitely hasn't improved matters in terms of the fact that we can just do the test and not worry about the patient and say you can have peanut, because even below the cut, if you're below the cutoff, you still may be in the 20% who actually react to foods. So I just want to emphasize that component-derived diagnostics, resolved diagnostics, have improved the situation, but it hasn't improved sufficiently for it to stop us from challenging people if we feel they need to be challenged. And very similar to other nuts. One thing which is a bit worrying also about the component-derived diagnostics is the cutoffs which we're looking at may be age-specific and also geographical specificity, and also their performance might be a lot worse if there is another age. So, for instance, in this nut study, if we look at the 95% specificity here for Cora A14, a hazelnut component, then this only has a 31% sensitivity. In other words, 70% of people will still react if below the cutoff. And once again, also this is very similar in terms of the other allergen. If we look at the 95% specificity, again the sensitivity is low. So just going on, these studies are a little bit of a worry because the studies may only apply for a selected age. There may be different cutoffs at different ages. There's a feeling that even in peanut, the geographical area might be important. If we take community-based studies, then the performance might be a lot lesser, because all these studies are predicated, some of them are predicated on the fact that these people are positive skin test to peanut already, and we really don't know about the analytical performance of these components at the 95% cutoff. So bottom line is that things have been improved, but they haven't been improved sufficiently to stop us from challenging people with foods. Okay, so why is this a problem? Essentially, there's a lot of problems with component-resolved diagnostics. There's irrelevant molecules. There might be cross-reactive allergens. We've got a tertiary structure, and some allergens may be just sort of representation of how much we can get and purify them. There may be variation between individuals, and there may be post-translational modifications. Pollens are very early stages. Some of the component-resolved diagnostics do pick up things that the traditional testing doesn't. But the problem is we really don't know how clinically relevant these things are. For instance, this is a pollen study, and it demonstrates that component-resolved diagnostics pick up a lot more olive allergy than the others, but it's very difficult to know the components of olive allergy as opposed to cross-reactive grass allergy, and whether or not they're relevant. And I think it's early stages there. Some people are now looking, and this is a nice study, proposing a sort of schedule for immunotherapy dependent upon component-resolved diagnostics. But once again, this is problematic because it doesn't prove whether or not selecting immunotherapy on this basis of these component-resolved diagnostics is any better than just selecting it on terms of skin testing or a specific IgE testing. And the complex studies are needed in order to sort of validate these sorts of things. Okay, now I'll very briefly look at microarray technology, and as you know, this is where you have a lot of different allergens on a chip, and it feeds on from component-derived resolved diagnostics in terms of the fact that each component is on a little chip, and so you get sort of hundreds and hundreds of different allergens. And this is a real problem in that it's very early stages, And but it looks promising in that this is a study on latex allergy, and you can see where the true positives will sort of come up with certain components, where the false positives will come up with other components. I went to one of the even though small amounts of serum can be used with this, and there's replicates, you can get replicates. The basic problem with microarray is we're back to the future in that the amount of allergen that can be put on each chip is limited, and therefore the sensitivity of microarray for these components has not been well evaluated, and you can get interferences with IgG, and so once again early days in terms of clinical uses. So in summary, I want to say that there have been great advances in terms of allergy testing, in terms of in vitro specific IgE allergy testing, that component resolved diagnostics does offer promise, but it hasn't solved all the problems. And I took food allergy as an example, whereas it does improve, in fact, the resolution of the comparison with challenge testing, but it's not good enough in terms of clinical practice, and that we still have to challenge a lot of people, particularly if they're below that cutoff, and that it's early days with microarray and pollen and aeroallergen component resolved diagnostics, in that the clinical studies haven't been done sufficiently to be confident of them. This is a personal view. This is a personal view based on allergy practices in Australia, and I'd be happy to take questions. Any questions? So I've gone into QA, and there was no questions on display. I'll wait wait a minute or two to see if there's any questions and anybody wants to put forward. What's your experiences with component resolved diagnostics? Yes, so will you make your slides available? Yes, no problems whatsoever. You mainly from I'll just click on to see where you come from, if that's okay. You're mainly from so a lot of you are from companies that make allergy testing, in vitro allergy testing equipment and stuff. To people, what's your feeling about component resolved diagnostics in terms of where it's going? Any views? No, so that's fine. Okay, so we might wind it up now. Thank you very much for attending, and I hope you got some information on this in terms of the sort of clinical application of these tests. Thank you very much.